And now, Brent, go ahead and take it away.
Great, thanks so much. And thank you, Blaise and Peyton, for inviting me to come speak. And thank you to the LGBTQ Health Program leadership and Dr. Subak for the opportunity to talk today about my program. My talk today is called Queering Reproduction, LGBTQ Family Building. And I always, whenever I talk about this topic, I do like to start with a disclaimer, which is that not everybody wants children and not everyone prioritizes genetic relationship to future children. But my talk, my clinic, and my research really focuses on how LGBTQ individuals can use medically assisted reproduction to have genetically related children, but things like co-parenting, adoption, foster care, childless living, and other arrangements are no less important. For an overview of today's talk, I'd like to talk a little bit about LGBTQ family building, a history and an overview of treatment options. I'll talk about some heteronormative assumptions that we see in the field of reproductive medicine. And then I'm going to talk about some of my research, first in the sexual minority assigned female at birth population, then gender minority assigned female at birth population, and then some of my newer work on sexual minority assigned male at birth populations. And I'll end by sharing a vision for the future of LGBTQ family building, both here at Stanford for the Q+ and just kind of greater. So in terms of reproduction, we often think about this in terms of a woman who has ovaries and a uterus and a man who has sperm. And that's kind of been the way that it's presented in textbooks and how we think about reproduction. And so I like to just point out that, reproductive biology is not a fairy tale. And the way that we often learn about it with multiple sperm competing to rush to the egg, where only one most competitive sperm, kind of rescues the egg to turn into a developing pregnancy. These kind of stereotypes are not really reflecting biological reality when we know that sperm actually move with really random movements and there's kind of not a lot of coordination there. So this is a quote from Emily Martin, who is a bioanthropologist, and she wrote that culture shapes how biological scientists describe what they discover about the natural world. One clear feminist challenge is to wake up sleeping metaphors, become aware of their implications, and rob them of their power to naturalize our social conventions about gender. And this really goes to the idea that, when we think about gender roles, and we even ascribe them down to the microscopic level, where we have egg and sperm, thinking of them as woman and man, even though that's not, doesn't reflect reality, it really limits our understanding of what the possibilities of reproduction are. And also just as we think about what family building options are. Another really famous scholar, philosopher, and gender scholar, Judith Butler, who is at UC Berkeley, has written a lot about this idea of gender trouble. And it's kind of this idea that gender is performative and there's nothing about it that is natural and objective. And I think what's been really interesting to see is I often have encountered in textbooks that we really ascribe a gender to egg and sperm in the way that they're described. And so I like to kind of extend her metaphor beyond gender trouble to the idea of gamete trouble. And the reality is when we think about gametes, we're talking about eggs and we're talking about sperm. And regardless of sexual or gender identity, as long as you have these three ingredients, this is what it takes for reproduction. And I think that's really never more apparent than in the field of reproductive endocrinology, where we do things like in vitro fertilization, where fertilization actually takes place outside of the body in a laboratory. And this is actually a picture of a specific type of fertilization technique called intracytoplasmic sperm injection, or ICSI. So for LGBTQ family building, we talked about the ingredients, but even if you have the ingredients or you're finding out which ingredients you have, what's really important is to kind of make no assumptions. And so if an individual patient or a couple or a relationship with more than two people present to you, the first really part of this process is to find out what gametes are there. What reproductive organs do you have? Are there testicles? Are there ovaries? Is there a uterus? And then once you start asking those questions, are they planning to use those gametes? Are they planning, just because someone has a uterus, are they planning to carry the pregnancy with that uterus? And so asking who is participating and how they'd like to participate is really the first step. And in terms of just a general treatment overview, and to be concise, I put sexual identities here, but the reality is, again, treatment options are really dependent on a reproductive organ inventory. And so you can't really just assume based on sexual identity, but just to kind of make it more kind of clear, for individuals that may identify as lesbian or be in a same-sex female relationship that are egg producing, options that we often think about are home or office-based insemination, or you can do in vitro fertilization, kind of the conventional approach, or you can do reciprocal in vitro fertilization, where one partner provides the eggs, embryos are created in the lab, and then the other partner provides the uterus for the pregnancy. For bisexual patients, really they are conspicuously absent from the literature, and again, options are just going to depend on what the relationship makeup is. For transgender and gender diverse egg producing individuals, we're usually talking about egg freezing before, after, and during gender affirming hormone therapy, which in this case is often testosterone. For gay or same-sex male relationships, we're talking about using an egg donor, using a gestational carrier, or who we might colloquially refer to as working with a surrogate, and in vitro fertilization. And for transgender, gender diverse sperm producing individuals, we're thinking about sperm freezing before, after, and during gender affirming hormone treatments. And that's usually thinking about estrogen and an anti-androgen medication. And there's also really a role for specialized urologic procedures and working with a reproductive urologist who actually focuses on this as well. When we think about heteronormative assumptions, one thing I often bring up is, this is kind of changing in the new generation, but for many people my age and older, when they came out, a very common refrain that you would hear is, oh, if you're gay, you're not going to be able to have children. And it goes back to this idea that we've really kind of have a heteronormative view of what reproduction looks like. I think we've shifted a little bit away from that, thankfully, and it's not that LGBTQ can't have children, but it's more maybe that they're not interested or they don't want to. And I think that was really portrayed a lot in the media and the lay press over the years. Again, that's changing, particularly in the Bay Area. But so I just kind of like to start with this brief history of LGBTQ family building. And this was something that I published in FNS Reports. And it basically just shows kind of how LGBTQ family building has gone through several key paradigm shifts. And there's been an evolution on how we think about LGBTQ family building, both historically, clinically, and kind of where we're kind of going. Starting in the 1930s, this is really when we see a lot of descriptions of what was then called homosexuality being pathologized and people having electroshock therapy, lobotomization, and castration. And it was a time where LGBTQ family building, of course, there were still LGBTQ family buildings that existed, but they were really in hiding, and they really had to respond to the fact that society thought that children needed to be protected from anyone who was kind of considered a sexual deviant or homosexual. As we move into the 1950s and the civil rights movement, that's a time where homosexuality, again, was classified as a mental illness. But it was also the time of the really hallmark Kinsey scale studies that really started thinking about sexuality as beyond the binary. So there were some evolving societal perceptions, but of course, still really a lot of progress to be made. In the 1960s, there was a sexual revolution. Homosexuality remained in medical textbooks as a mental illness, but there was increased visibility for LGBTQ parents. Overall, though, the kind of concerns for the best interests of the child remain, and actually many individuals would lose custody of their children if it came to light that they were part of the LGBT community. In the 1970s, this is kind of following the Stonewall riots, and this is kind of the gay liberation movement. This was a time where there was actually quite a bit of kind of progress moving forward. There was also, at the time, there was a lesbian grassroots insemination network for individuals in that community to do inseminations at home. Homosexuality was removed from the DSM, and there was really starting to see more LGBTQ advocacy, able to have visitation of children, able to get custody, and even able to adopt openly in certain states on a case-by-case basis. Unfortunately, a lot of this progress stalled in the 1980s, and that was during the HIV/AIDS crisis. But at the same time, in the early 80s, it was both the advent of in vitro fertilization and certain sperm banks, particularly in California, actually began granting access to single and lesbian women to have the option to buy donor sperm. And so this early 1980s has been heralded as kind of one of the first Gatey booms, where, you know, the combination of having IVF and then also being able to use donor sperm, adoption laws becoming a little bit more favorable. It was just a time where people really saw that as a future. But again, lost a lot of progress because the shift and focus became more on the HIV AIDS crisis. In the 2000s, the American Society for Reproductive Medicine published guidelines that supported access for fertility treatment for lesbian, gay, and unmarried persons. And this is really important because a lot of fertility clinics, and even some today, were only treating individuals that were married. And of course, if gay marriage wasn't even legal, that was even a further barrier. But there was an increasing trend in the 2000s of more societal acceptance and permissive legislation for LGBTQ parents. And then in 2020, we're really kind of shifting in an era of same-sex marriage equality. There's more of a focus on diversity, equity, inclusion, and kind of all different aspects of life. And the American Society for Reproductive Medicine has broadened and affirmed access to fertility treatment for all LGBTQ persons. And importantly, in October of last year, the ASRM actually changed the definition of infertility to include anyone using donor sperm, donor egg, or needing to use like a surrogate for the uterus for pregnancy. And this is a big jump because it means that insurance companies now can't say, we're going to deny coverage for services just based on the fact that someone's quote unquote not infertile. With this new definition, I think we're going to see a lot of physician advocacy around more kind of inclusive coverage for populations. So of course, you know, something that makes it challenging to know about LGBTQ family building and kind of where we're moving is that this is a population that historically was not counted. And it wasn't until July of 2021 that the Census Bureau first collected LGBTQ data. And from that, we got the information that maybe around 7% of the US population is LGBT, though of course it's likely an underestimate for a variety of reasons. They didn't specifically address LGBTQ family building, but the Family Equality Council did do a national survey, and they showed that about a third of LGBTQ respondents either already have or are considering having children. So, you know, this is something that has, you know, always been. LGBTQ family building has existed, and it's just kind of changing, and the landscape is becoming more accepting and more permissive. And so it's really the right time to really kind of focus on how we can make this better. When I was a medical student, I worked with my colleagues from Johns Hopkins, who I had met as a public health student. And we actually did a small study where we looked at all of the fertility clinics in the United States to see if they had any content related to LGBTQ family building. And what we found was only about half of websites had any content on them related to this topic. And this is really important because for many patients, the internet is their first step to find information on something they want to learn more about. This study, we were very generous. So we, you know, even if you had like a rainbow flag on the website, or you just mentioned one thing that could be considered LGBTQ friendly, it was considered LGBTQ content. So even though it seems maybe like half is not so bad, many of these sites, it was kind of the bare minimum, and there wasn't really any level of detail for patients to learn more. Studies have been repeated recently that have been a little bit more stringent, and they're still sitting around the same 50% number. So haven't seen a lot of change in that. So that's an area for improvement for sure. In terms of other heteronormative assumptions that we often see, is this idea of using a standard therapeutic approach. So infertility clinics are really, you know, they were designed with a heteronormative kind of penis and vagina intercourse has not been working. So how can we help an individual who presents after trying that for 12 months? And so they don't necessarily, they're not structured around this idea of LGBTQ family building. And in fact, it's not even just heteronormative. A lot of infertility clinics, because the physicians that worked there were OBGYNs that trained primarily in a patient population that was assigned female at birth, a lot of times you'll find fertility clinics don't even really have like a restroom for someone of a different gender or someone who is assigned male at birth. So these are places that can be very gendered and very, heteronormative. And it extends into the treatment options. So if you're a fertility doctor and you didn't really learn anything specifically about LGBTQ family building, and when someone comes to your office to do, say, an insemination where we put sperm into the uterus, normally, for someone who has infertility, you give them fertility medications to help increase the chances of pregnancy. But that might not make sense for someone who actually isn't infertile. They're just coming because they're using donor sperm and they need the clinician to place the sperm there. Another approach that was used across the country, but is thankfully now kind of falling out of favor, was the idea of putting 2 inseminations in one cycle. And so just to kind of orient for those who are less familiar, so here you'll see the uterus up top and the cervix here. And so for an intrauterine insemination, what we do is, since the egg is released here from the ovary and comes down the fallopian tube, we actually can put the sperm through a catheter directly into the uterus and meet here in order to assist for fertility treatment. Now, in fertility clinics, a lot of times they were doing 2 inseminations with the thought, if you're infertile, 2 is going to be better than 1. And so what I was interested in was, well, it doesn't make sense to me that 2 inseminations is going to be better than 1 for someone who actually has never even had a sperm exposure. They're just coming to use donor sperm. And so I partnered with EVRMA, which is one of the world's largest providers of fertility care. And we looked at this process called double insemination, of doing 2 sperm insemination cycles. And we found that in their lesbian and single patient population, almost 90% were doing this double insemination. Though if you look here to the right, you'll see that there was really less than a 2% difference in clinical pregnancy. And so, they were doing it in heterosexuals, so why not also do it in single and lesbian? And the big difference here is, in a heterosexual couple, that just meant that the partner would give 1 additional ejaculate at the clinic. And so wasn't a huge ask in terms of that. Could be more for some individuals than other, but essentially didn't really increase the cost. Whereas if you are a single or a lesbian individual that's buying sperm from a bank, that's $1,000 per vial. So you were asking a patient to spend an additional $1,000. And on average, patients do this 4 to 5 times. So then on average, you're asking patients to spend $4,000 to $5,000 more, really for a very minimal and not statistically significant difference in clinical pregnancy. The last heteronormative assumption that we often see is that this is a low-risk population. So this is kind of the flip side. So you could think of them as treating them as they're infertile, or you could make the opposite error of saying, oh, they're not infertile, so we don't really have to worry. We can kind of do whatever approach, and that will work. But we might be overlooking some health issues there and some risk factors. So when we think about risk factors for LGBTQ family building, one of the most obvious is health access barriers. Just not even being able to get the appointment, not even being able to see a clinician. And this kind of most obviously could result in someone being much older when they present to the clinic. And we know that increasing age can have negative impacts on fertility. There also can be poor preconception health. If this is a patient whose doctors are never even thinking about LGBTQ family building, it may never come up. The idea that maybe you should be taking a multivitamin or a prenatal vitamin, or that you should be optimizing your health for either a future pregnancy or just future reproduction. And then also the use of donor materials. So the use of donor sperm has really had less kind of severe risks associated with it, but there is some evidence that in donor egg cycles, there could be increased risk of certain things like C-section or postpartum hemorrhage or preeclampsia or other hypertensive disorders of pregnancy. And then there's also just this issue of there's really no tailored clinical guidelines for LGBTQ family building. And so when clinicians don't have guidelines to how to do, it really means that it's not standardized. And so there could be things that could be potentially causing harm because we really haven't had a guideline to follow up and see what the best approach is. And when we think about these harms and things that we want to learn more about, For the gender minority population, a lot of times we're thinking about, well, what is the impact of gender-affirming hormone therapy on fertility and future reproduction? For sexual minority patients assigned male at birth, we're seeing in some data sets that I have that we're seeing that more than one embryo is being put back in during an embryo transfer. And so for those who might remember all the news coverage for situations like Octomom, where people were going to fertility clinics and having way too many multiples and all the risks associated with that, fertility doctors have done a really good job of reducing those rates because we've moved to a process of only using one embryo per transfer. But we're actually seeing in sexual minority patients that we haven't seen that same decline in that practice. And we're not sure why that is. Is it because there's not a guideline, or is it because patients are requesting it? Is it because doctors aren't following guidelines because they think it's different? We really just don't know. And then for those sexual minority patients assigned female at birth, there was a great study done by Shady Grove, which is a private practice fertility group that's partnered with the NIH on the East Coast. And they showed that in this population, there was about a 5-time increased risk of multiples in sexual minority assigned female at birth populations. And the thought behind that was that individuals who are given fertility medications that don't need it, you don't increase their chance of success, but you do increase their chance of multiples. And we actually did some internal work here at a combination of data both at Stanford and UCSF, and we saw that actually in lesbian patients, over half of them were using medications. And clinically, we just wouldn't expect that half of those patients would actually need fertility medications in addition to the insemination. In a study that was led by Stephanie Leonard and Juno Abaden-Maliver here at Stanford, they looked at California birth certificate data linked to hospital records, and we saw that there was a 16 times higher use of medically assisted reproduction in sexual and gender minority patient populations, and that number is coming up again. There was also a 4 times higher risk of multiples in sexual minority women in this data set. And so I think that this is just kind of an area of further exploration. And during my time as a fellow here at Stanford, I was actually interested in whether or not this was always the case. So we were looking at a modern data set. And so I wanted to think about ways that we could see, has there always been an increased risk of multiples for sexual minority patients assigned female at birth? And so to do that approach, I used the Nurses' Health Study, which is a longitudinal cohort that's based at Harvard University. And particularly, I used the Nurses' Health Study 2. And the reason I did this is because it's very rare to find a data set that asks about sexual orientation and gender identity. It's also very rare to find a data set that asks anything about fertility treatment or any details about fertility treatment. And this data set uniquely did both. And so we were actually able to look at some key variables. For sexual orientation, we were able to look at multiple dimensions of orientation, including identity, attraction, and behavior. We were also able to assess sexual fluidity because sexual orientation was asked about in multiple time points. And we were able to create more granularity beyond the binary of just kind of straight or gay, and actually create 5 different distinct groups: completely heterosexual with sexual minority status, which referred to those individuals who identified as completely heterosexual, but also said they had some form of same-sex attraction, same-sex sexual contact, or a past sexual minority identity. Mostly heterosexual, bisexual, lesbian, or gay. And then in addition to that, we had for medically assisted reproduction, we had information on the use of oral medications and injectable medications used for fertility. And we also were able to look at both insemination and in vitro fertilization. And that's a really important point here because most data that is collected in the United States on fertility treatment only focuses on things like in vitro fertilization. And there's not really a national database that asks about insemination. So this was another really great way to kind of get more information because this is a population that uses donor insemination at very high rates. And then we were able to look at multiple live birth because we had individual pregnancy outcomes reported from 2001 to 2009. And I don't want to spend too much time on the details of the study because we have a lot to get through today. But I wanted to just share that we did do analysis of multiple live birth. And what we found that was while there was an elevated risk of multiples in sexual minority women, it was not statistically significant. We're actually still, this analysis is actually still ongoing, and we're doing a more nuanced approach in the next iteration. And we're going to repeat this analysis with sexual orientation closest to pregnancy, because we think that we may be kind of hiding some of the results by looking at a broad data set over time. And our preliminary research is showing that it actually is a statistically significant difference. And so I'm hoping that those results will be out shortly. One thing we were limited by in this data set, though, was we didn't have information on current partner sex and gender identity. So we were really only able to look at the sexual minority patient population. And that's where another cohort comes into play, which is the Growing Up Today study, which actually enrolled the offspring of the Nurses Health 2 study. And this is from a poster presentation that we presented last year, one of my colleagues, but this was just accepted in Human Reproduction, and it's now in press. And so in this study, we had 3,517 participants with 6,935 pregnancies. And among them, there were 91 pregnancies among bisexual participants, 37 pregnancies among lesbian participants. But again, this was a focus on sexual identity, which doesn't really tell you what we're most interested in, which was we were interested in pregnancies that resulted from individuals in same-sex relationships. And this data set actually had granularity for us to do that. So we actually were able to look at female same-sex relationships, and of those, there was 47 pregnancies. Those individuals had 5 times higher uses of medically assisted reproduction, and that includes things like the inseminations that I was talking about, which could either be intrauterine, intravaginal, or intracervical. You'll notice, though, that these are still kind of small numbers overall, and it really didn't focus on the clinical outcomes. It was just kind of focusing more on the use of fertility treatment. And so that kind of got me thinking about, well, how can we study clinical outcomes in a gender minority population, particularly those assigned female at birth. And so for this population, there are a lot of challenges in identifying subjects because electronic medical records don't always do a very good job. And so it's hard to retroactively look back to identify patients. What we know is mostly from small heterogeneous single site studies, kind of a clinic here and a clinic there. And there's just really these huge knowledge gaps in terms of limiting counseling on how an individual, particularly a pediatric individual, might decide whether or not to freeze eggs based on when they're starting gender affirming hormone therapy. And because this population is usually excluded from insurance coverage or state mandates that usually do require to cover fertility preservation, this cost being a major barrier, not only is a barrier for patients, it's also a barrier for research, because if very few people are able to go through this process, there's not many patients that you can actually study to kind of decide what the best approach is. So that got me thinking, well, what if we looked at patients with inclusive fertility benefits? And so I actually partnered with Progeny, which is a company, a fertility benefits company, that a lot of the tech companies in Silicon Valley actually contract with to give patients and their families really inclusive fertility benefit coverage that extends to the LGBT community. And we really don't see this in a lot of places in the United States. So it's a very unique opportunity in the Bay Area to partner with them to find patients that actually have coverage. And this is from an abstract that we presented at ASRM last year. And this maybe is kind of a no-brainer, but I think it's still important to kind of show these things. But in patients in this data set that had coverage, almost 90% of patients actually pursued treatment. And this is really a big finding, particularly for me, because I can tell you anecdotally, I see so many patients in my practice that are thinking about starting gender affirming hormone therapy, and they either want to freeze eggs or freeze sperm, but then they decide not to go through with the process because it's just too expensive. And so really just kind of highlighting that if they have coverage, most patients go through, I think is really important to show that health access barrier. In our data set, we had 6 individuals that went on to do in vitro fertilization and create embryos. We had 7 individuals that did egg freezing and 2 individuals that did insemination, 2 individuals that did no treatment at all. And I think what was really great about this project is that we could focus in on the IVF and the egg freezing to do a little bit more about clinical outcomes that we didn't have in our prior data sets. So for those who aren't familiar, I just wanted to do a quick review of egg biology, or for individuals that are often born XX. So in utero at 20 weeks gestation, an individual that's assigned female at birth typically has tens of millions of eggs. And then by the time that they're born, that's down to about 1 million. In puberty, we're talking about hundreds of thousands. And then that most fertile decade, which is that 20s to 30s, there is kind of a steady decline that continues, with a steeper decline in fertility really being seen. No magic number. You often hear the number 35 thrown around, but the reality is in the late 30s and early 40s is when we see a more significant fertility decline, with the average age of menopause being around the age of 51, when there's about 1,000 eggs left. So this is all in context of when we think about how many eggs should someone freeze and how many eggs do we expect them to have. And in order to assess that, we often do that with a blood test as well as an ultrasound. And you'll see here that the blood test goes down with age that we test. And then this is an ultrasound that shows you the number of follicles that you can see in an ovary. We sometimes tell patients it kind of looks like a chocolate chip cookie. For some reason, clinicians love to use food analogies, but I can see that. So I think it does make sense to explain it that way. And when we think about what in vitro fertilization looks like, what it typically involves is we use an approach where we use an ultrasound that goes through the front genital opening, sometimes referred to as a vagina. And this ultrasound probe actually has a needle attached to it. And it goes directly to the ovary, and then we're able to aspirate each individual egg from the follicle. Once we get them, if they're making embryos, we put the eggs in a dish in the lab, expose them to sperm, and then we make embryos after a period of incubation, and then embryos can be put back into the uterus. So this was one of the things we wanted to study. What did the outcomes of this process look, particularly in a transgender population assigned female at birth? And so we also wanted to break down outcomes based on a couple of different things. And while we did have a very small sample size, even though this actually was a national data set, it allowed us to start thinking about these different issues. So one of them is looking at clinical outcomes before an individual starts testosterone at all. And what we saw was reassuring outcomes in the number of eggs that were obtained. We also could look at clinical outcomes after someone had started testosterone. And again, in these, we saw reassuring rates. We also were able to look at clinical outcomes. There was one patient in the data set who had started testosterone and then did not stop it. So sometimes you'll hear that doctors will say you have to stop the testosterone before you go through the practice. We really don't have enough evidence to say that. And this is just an N of one, but there are some other case reports that showed this similarly. We also looked at individuals who had started testosterone and only stopped it briefly. So this individual stopped for 1 month. And then we looked at two individuals that had stopped testosterone for a longer period of time, 5 and 30 months respectively. Now, interestingly, the one who stopped for 30 months actually had a lower egg yield, but they were also an older patient. But we actually had more information on this patient because they actually went through the process of creating embryos. So of those 8 eggs, they were exposed to sperm, they turned into embryos, and they actually ended up with 2 genetically normal embryos. So overall, this was actually also a very successful cycle for this patient. And I'm sure many of you are thinking, well, you had 5 patients, right? So this is just kind of highlighting what a challenge it is to do this research, even when I used a national database. And so that got us thinking when we presented this at the national conference in New Orleans, how can we get more data and larger sample sizes? And so that brings me to kind of step 4 in this approach for assigned female at birth, which is that we are in the final stages of a data use agreement with the University of Michigan, and we are creating a national database of multiple different academic centers where we can kind of pool the results of our patients together so that we can really begin looking at these nuanced questions about testosterone use with a larger data set. And so that was a lot of focus on assigned female at birth. So I want to change gears a little bit and talk about an individual population assigned male at birth. And so this is a patient population that's really conspicuously absent from the literature. And most reproductive health research has focused on sexually transmitted infections, particularly HIV, and really left reproduction out for this group. And even when there is research on what I'll say kind of gay men or individuals assigned male at birth building their families, it often focuses on the relationship of the gestational carrier and the intended parents, as opposed to the actual intended parents themselves. And this is a patient population that is still turned away from fertility centers across the country. And in fact, it was a big reason that I decided to go to medical school myself, because when I shadowed a fertility doctor at Johns Hopkins to learn about how gay individuals can build their families, they kind of said to me like, oh, but we don't treat that patient population here. And I kind of, looked into that and realized that many clinics don't take care of gay men that are building their families. And so this is really an area that we just have to be better. This is further complicated by the fact that there are local restrictions and laws that might limit the ability to use a surrogate in certain states. Cost is another huge barrier for this patient population. It's a barrier for everyone, regardless of sexual identity or gender minority. Fertility treatment is so expensive, but for this patient population that uses a combination of an egg donor and a surrogate, it's roughly $150,000 to $200,000 per child. So this is really unaffordable for almost everyone. It's just such a huge number. And so again, how do you kind of study something that is so rare if it's so expensive? And so I kind of thought about the same approach. Well, what if we looked at patients that had inclusive fertility benefits? And so I partnered with the same company, Progeny, and we actually did a study that was published in FNS Reports that looked at 7 single and 56 coupled intended fathers from 18 different fertility centers across the country. And we were able to start looking at some of the clinical patterns and outcomes. So we saw that many of them, both of them, like to use their sperm as the source for the embryos. Many of them, almost all of them, use genetic testing of the embryos. There was a majority that did do that process of only using one embryo for transfer, but we saw that 26% were transferring more than one embryo. And for those who aren't familiar, if you're following the American Society for Reproductive Medicine guidelines, that percentage should really be as close to 0 as possible. So 26 is a really large number. And then we also saw that the majority had a singleton birth, but about 15% did have twins or beyond. When we looked at the live birth rate, we actually saw that 85% of them were successful, bringing home a baby at the end of the process. And as fertility doctors, we aren't used to seeing success rates that are that high, because in general, those numbers are closer to about 50%, even when you have a genetically normal embryo put into a healthy uterus. And so this was kind of a stark finding. And so I was interested in how this does, in fact, compare to the heterosexual population. So going back to those ingredients of patient, partner, and patient for heterosexual reproduction, we see that a live birth per embryo transfer in all comers is about 46%. And now remember, this is a patient population that comes to a clinic oftentimes after trying on their own for a year without success. When we look at this number in this same-sex male couple situation, we actually, again, saw that number being 85%. But this was kind of comparing apples and oranges because, heterosexual couples can also use donor sperm. They can also use a gestational carrier. And we were also comparing, this is 2 different databases. And so what I wanted to do next was I wanted to use a national database that uniquely asked about both heterosexual and same-sex male couples that are using these technologies. And we were actually able to do this with the support of a wisdom grant here at Stanford, because in 2017, the Society of Assisted Reproductive Technology actually began collecting data on same-sex male couples for the first time. And so this will be presented later this year at the European Society in Amsterdam for human fertilization. And it'll be the largest study ever published on same-sex male couples building their families. And we were able to look specifically at how the live birth rate compared to the heterosexual population using the same data set. And so for context, if a heterosexual couple where the patient provides the egg, the partner provides the sperm, and they use a surrogate for whatever reason they need to use a surrogate, the live birth per embryo transfer is about 54%. In this data set, if a heterosexual couple used donor egg, the partner's sperm, and a surrogate, the live birth per embryo transfer is 62%. And in our data set, in a same-sex male couple where we have donor egg, we have the patient or the partner, either one of them could be the sperm source and using a surrogate. We saw that the live birth per embryo transfer was 69%. So even when we control for these other factors, there's still something about this that was giving us higher success rates. And we did an analysis where we controlled for many different confounding factors and saw that this was a statistically significant increase in the live birth rate. But I kind of skipped over the demographics of the intended parents to kind of tell that story. And so I do also just want to highlight that we were able to look at a large population of same-sex male couples. The majority of the database was individuals that identified as white or Asian. But unfortunately, this is a database that does a very poor job of actually collecting race and ethnicity data. So we're hoping in the next iterations that we will have less missingness in this data set. We also looked at where these patients were coming from and where their clinics were. Interestingly, most of them were in the West, both the patient where they're from and also the clinic they go to, but the Northeast was also common. And we actually took a closer look and put the patients on a map to see the different places where the individuals were from doing these same-sex male couple cycles. And so most of them were actually from California. 28% of the cycles were in California, 16% were in New York, 5.5% were in Texas. Those were kind of the biggest states. But you'll notice that this is only 3,000 cycles. And I don't know how much I kind of highlighted before, but we actually had 6,000 cycles in the database. And so we were wondering if maybe there was 3,000 cycles missing with their location. But it actually turned out that the other half were international same-sex male couples traveling from one of 23 European countries or another country abroad, specifically to the United States to build their families. And interestingly, of those international cycles, almost half of them traveled specifically to California for care. And I'd love to say that this was Stanford and the Q+ program, but the reality is most of them were going to private practices in Los Angeles because that has really been a hub for LGBTQ family building for many years. And so in terms of clinical patterns that we looked at in this data set, we also were able to look at sperm source, and we saw about half of them wanted to both use their sperm. We saw that most of them, again, are using genetic testing of embryos. And in this data set, we saw that, again, most were only transferring one embryo. But again, we're seeing that there is still a large amount transferring more than one embryo, 22%. We also saw that in the heterosexual couples. So this is an area that in this particular patient population, donor egg and gestational carrier, we're just seeing a practice of transferring more embryos than should be done. And we were really interested in how these decisions are made. Is it led by the clinician? Is it led by the patient? And so for the next step, I actually partnered with the Department of Genetics, and I'm working with a genetic counseling master's student here, Sean Daly. I actually met him in one of the classes that I guest lecture in at the main campus. He approached me after class and he was interested in the same question. And so we're actually actively recruiting now to do semi-structured interviews where we're asking same-sex male couples about how did they choose whose sperm to use? How did they decide if they were going to do genetic testing? If they did they choose the sex of the embryo? How was the decision made about a single versus the double embryo transfer? And how did they pick their egg donors? And for step D, which is also step 5 for those individuals assigned female at birth, I really kind of wanted to end by highlighting this new exciting program, which is the Q+ Family Building Program, where we've leveraged substantial support from the Stanford Children's Hospital to build a unique program that will provide specialized care to the LGBTQ community in a way that's really never been done in an academic center in the United States that I'm aware of. And I actually don't think that there's a center like this in the world. So it's really the first of its kind. And we will have a medical director, a physician assistant, nurse, mental health clinician, and a patient care coordinator. We will also have research support with a clinical research coordinator. And we will be able to improve our sexual orientation and gender identity data collection and expand services for all LGBTQ patients. I wanted to highlight some of the things that the program has already done in its short time. So we've really expanded low-cost options at the clinic, including medication substitution, so using oral instead of injectable medications whenever possible. We've also modified and have personalized protocols where we use lower doses of medications, less blood work, less ultrasound visits. And we also have begun offering InvoCell. Myself and our lab director and one of our fellows traveled to Birmingham, Alabama last year to learn how to provide this low-cost option, which uses an FDA-approved vaginal incubator for eggs and sperm. So you can cut off about $10,000 for the process and still go through something similar to IVF. So great option for our patients. In the future, I'd like to be able to expand some discount programs for patients that are starting gender-affirming hormone therapy, and also work with the hospital to see if we can do some bundled pricing, because currently our services are all a la carte. For our community partnerships, we have a couple community midwives that we can either refer to or they can refer to us for patients who either want less medical intervention or maybe patients of midwives that end up needing more care. And I didn't really talk a lot today about gender minority assigned male at birth patients. And that's actually because historically those patients have really been directed to go directly to a sperm bank. And so we work closely with the Sperm Bank of California for those patients. And historically, they didn't really have an option for someone to talk to before going to the bank. So in the new Q Plus program, we now offer information gathering counseling for patients to talk about freezing sperm before starting estrogen or an anti-androgen. And we also work closely with our reproductive urologists. If they are unable to produce a sample at a bank, we can actually do that directly at our clinic. We also are working with Reproduction to provide long-term storage options for our patients, and also for patients who have a history of HIV. Historically, those patients were referred to UCSF, but starting last October, I created a new program for patients with HIV that we can now take care of them, and we store the materials offsite per protocol to be in line with certain FDA regulations. And we have a partnership with the Rainbow Chamber of Commerce in Silicon Valley to just make sure that everyone in the community knows about our program. And for our next steps, we're planning to create an advisory board and do some more community engagement and outreach to the LGBTQ centers in the Bay Area to make sure they know about this new program. I mentioned earlier that there's a new definition of infertility, and so that's really exciting. This was a great piece in NBC Bay Area that featured the new definition and our clinic. And I also do want to highlight that there is an ongoing class action lawsuit to expand inclusive coverage for certain LGBTQ subgroups that's ongoing. There are physicians involved in that case. I also work on several hospital committees to make sure that we have better coverage. Those are listed here. And I hope to have some partnerships with our colleagues in the Stanford Law School, because I think there's just a lot of overlap in terms of when laws change, how they can impact access to care and treatment. For teaching, we have regular clinical rotations with medical students, residents, and fellows. I also have several guest lectures that are listed here in a couple different classes. And we really are able to talk about LGBTQ family building with a diverse group of students beyond just the School of Medicine, which is always a really great experience. And one day I envision the possibility of even having a queering reproduction course. And I'd like to incorporate a patient panel where different LGBTQ individuals come to share their stories. For clinical guidelines, I'm currently one of the lead authors for the American Society for Reproductive Medicine. And later this summer, we will have, for the first time ever, guidelines specifically for reproductive endocrinologists to do LGBTQ family building. And we'll be presenting some of that work at the Donor Egg meeting, which is going to be next week in Charleston, South Carolina. One day, I would like to envision that we have our own Stanford Q Plus LGBTQ Family Building Conference, and where we could bring experts from all over the world to talk specifically about LGBTQ family building. And for research, there's really just so many opportunities here because LGBTQ individuals have been left out of research in this area. Really, there's such low-hanging fruit to do any type of research, filling data deserts. We can do prospective data collection, health services research. We're doing a cost-effectiveness research right now led by Ariane Horshed, one of our fellows. We can do implementation science, and we're also planning to do some translational science partnering with some of our industry partners. For academic partnerships, I was able to cultivate a lot of relationships, both as a resident and now as a fellow. We also have several international partners. As I mentioned before, I'll be going to the Netherlands in July to present our work on same-sex male couples. And then in October in Denver, I will be partnering with a colleague from Portugal to present our work on reciprocal IVF, particularly in same-sex female couples. And then we work with Men Having Babies, which is an international nonprofit, and they've been helping us recruit for that qualitative study that we're doing with the Department of Genetics. For next steps, we're doing a binational analysis of same-sex male couples in the United States compared to those in Canada. There are different laws in the two countries, and so we're interested to see how that might impact outcomes. For industry partnerships, as I've mentioned, I've worked a lot with Progeny. I've also worked with Zymo, which is a serum epigenetic testing company, and we published on that previously when I was a resident. And I'm now working with Inherent Biosciences, which is an up-and-coming company that is doing epigenetic testing of sperm. And I think it could be a great way to help decide whose sperm to use, particularly in situations where there's more than one sperm source. And for the future of LGBTQ family building, I think what we're going to see in the next 10, 15 years, maybe 20, is that eggs and sperm will actually be created in the laboratory in a process known as in vitro gametogenesis. And it will really revolutionize same-sex reproduction. And I think the Q+ program is going to be very well positioned to partner with, there's actually 2 companies here in the Bay Area that are focusing on this work. They're keeping their research very close to their chest, but I think we are well positioned to work with them as this field develops. We also have close connections with Oregon Health Sciences University because Oregon has very permissive regulations for embryo research, unlike other states in the United States. Even California, who's very permissive, doesn't have the same permissive regulations as they do. So for disclosures for this talk, this is a list of all of the grants and awards that have supported my work, including an NIH loan repayment program. And it really does take a village. These are just some of the people that have helped me on this journey during my time as a fellow and now as an instructor. I do want to leave time for questions, so I won't go through each of their names. And then these are some additional acknowledgements. And I'm really thankful to the Q+ team that have actually come today to support me for this talk, and happy to take any questions.
Wow, Brent, absolutely incredible. So exciting. So we do have 5 minutes for questions. If anybody would like to raise your hand to ask a question, or drop your question in the chat, I'll help maintain the chat. But I feel like I need to watch that video about 2 times so I can start to process everything that you shared. It's so comprehensive and so amazing, but what an honor to have you here with us.
I have a question for you, Brent. First of all, thanks for your presentation. It's very, very helpful. Because a lot of this ends up being because given the extraordinary polarization we have in our society today, what do you think you should be doing in terms of, particularly as you talk about trying to create different stakeholder groups? Where are the ethicists in terms of some of this work, in terms of helping people understand that this isn't unusual, or at least it shouldn't be?
Yeah, that's such a great question. There's actually, reproductive medicine is a field that is really entrenched in bioethics because there are so many things that our field does that have kind of started as controversial and become more accepted. In vitro fertilization is a great example of that, right? So that used to also be kind of, seemed too foreign and too futuristic. So there are some great bioethicists that already work in our area. And we even have, at our very own law school, Hank Greeley has done a lot of work around reproductive bioethics. And so I think we actually could even have partnerships even within Stanford that, people that have already really started thinking about these issues. And there is also a lot of overlap with other reproductive justice issues. So really finding those stakeholders anywhere we can is a great place to start. But I think we have people already at Stanford, which is a good first step.
Thank you. That was a great question. And we have one in the chat from Zakaya. Let me know if I mispronounced that. The question is, do you have any resource? Well, first, you got a lot of praise in the chat, so this also starts with how fantastic this is. But the question is, do you have any resources or partnerships for postpartum support, such as with lactation, breast, chest, body feeding?
Yeah, that's a great question. So we actually do have a lactation consultant at Stanford that has some great resources for this. The Q Plus program itself, we actually transition care at 10 weeks of gestation. And so that would be one of our partners in either the larger LGBTQ health program or one of our partners that are working on OB. But I'm happy to get those resources and then circulate them so they can be shared, because we do have folks that work on that here.
Thank you.
Okay, we have about a minute or two left if we have a final question from anyone. Are you raising your hand, Brent?
No.
Well, I guess I will wrap us up with a question, which is just, if we want to stay engaged or if we can support or make referrals, what are the best ways for us to kind of distribute information about either getting engaged with the Q Plus program or people who are interested in accessing these services?
Yeah, so I think we actually have a new website that actually just went live, which is qplusfertility.stanfordchildrens.org. And so that would be a great way to kind of engage with the program. We have our own phone number that you can contact to get in touch with the clinic. For Stanford physicians, they can actually refer to our program through Epic. And then outside providers can refer to us just by calling that number. And then, otherwise just reaching out directly to me would be a great way to start. We now have our full team. So we have Benita Barron, our patient care coordinator, Julia Josowitz, our physician assistant, and Sarah Perron will be starting actually next week, our new IVF nurse. So the team is totally coming together, and it's a really exciting time.
Wonderful. I think I got that new website in the chat. I know it's 1 o'clock, so out of respect for everyone's time, we will go ahead and close this. But please, one last round of applause for the incredible work through the Q Plus Family Building Program and Dr. Brent Monseur's leadership.